This is Lauren Dunlap, Executive Director for Advocacy and Awareness for Immune Disorders Association, or AAIDA, in Charlotte, North Carolina, and we are so pleased to host today's webinar. AAIDA's mission is to advocate for patients living with primary immune deficiency, secondary immune deficiency, and autoimmune diseases to create awareness and conduct research to find cures for these different groups of diseases. We would also like to send a huge thank you to our friends at Allergy and Asthma Network for their continued support and involvement with AAIDA and assisting us with educational webinars such as this one. And we are so excited today to be presenting AAIDA's second educational webinar and are thrilled to be joined by Dr. Meredith Dasher, who will speak on immunity, skin cancer, and sun protection. Dr. Dasher is a board-certified dermatologist who received her undergraduate degree from UNC Chapel Hill and her medical degree from Tufts University. Dr. Dasher completed her dermatology training in combined Tufts and Boston University residency program. After completing her training, Dr. Dasher practiced 2 years in Marlborough, Massachusetts, before returning to her hometown of Charlotte, North Carolina. Dr. Dasher has been in private dermatology practice in Charlotte for 15 years and currently treats dermatology patients at Tryon Medical Partners, an independent multi-specialty group. Dr. Dasher's special interests in medicine include the prevention, early detection, and treatment of skin cancer. Dr. Dasher, we are so pleased that you could take time in your busy schedule to be with us today, and we look forward to the information that you have to share with the audience. Go ahead, Dr. Dasher. Thank you.
Thank you, Lauren, for the introduction, and to Sally for helping us coordinate the webinar. I'm honored to speak with you today about my topic. And it's a timely topic because May is the Skin Cancer Awareness Month. And wouldn't you know that right now I can't get my slides to advance. Let's see if I do it this way. There we go. So Lauren said perhaps it would be nice to focus on something other than COVID-19 since we're hearing so much about these conditions today during the pandemic, but I couldn't help myself. So before we get started, I did want to talk a bit about COVID-19 and the skin. The first series of patients that I became aware of was from a single hospital in Italy, where they had 88 confirmed patients and 20% of them had associated rashes. Just under half had the rash at the onset of their other symptoms. The appearance of the rashes was quite variable. There were often red patches, sometimes in a net-like pattern. Some patients had hives, and others had bright red dots of bleeding under the skin called petechia. It did not seem that the severity of the rash correlated with the severity of the overall illness. Since this first series, it seems that there is a more specific presentation that's becoming more widely known, and that is called COVID toes. So COVID toes describes red or purple areas on toes with swelling and a variable amount of tenderness. It resembles pernio or chilblains, which is a condition some patients get when they're exposed to more cold or damp conditions. With COVID toes, it does not seem that damp or cold conditions are required, and many of the patients reported come from warmer parts of our country. I'm sure you can find lots of images of COVID toes online at this point. The one on the left is from Business Insider. The one on the right is a patient of one of my partners at Tryon Medical. So what to do if you have a new and unexplained rash? I would recommend you monitor your temperature and monitor for other symptoms, especially cough or shortness of breath. Have a low threshold to contact your doctor. And if you are confirmed to have COVID-19, ask your doctor to report your case. The American Academy of Dermatology has started a registry to try to better define the skin findings of the novel coronavirus. To date, there are over 400 cases in the registry, and just under half of them are patients with COVID toes. One thing I think is of interest is that this presentation seems to be more common in younger patients and seems to be a sign of a milder form of the disease. All right, so back to my topic. Today, my goals are to review the basic role of the immune system in both the prevention and formation of skin cancer and other cancers. Discuss increased risk of cancer, including skin cancer, both with primary and secondary immune deficiency. We'll discuss the interaction between infections and immune deficiencies in certain types of cancer. I'll then give tips and show a lot of photos to help you recognize the 3 most common skin cancers that we see. And lastly, go over sun protection, including sunscreen, a few of the controversies surrounding sunscreen, sun protective clothing, and the role of supplements. During that portion of the talk, I will be talking about some brand-specific products, particular brands of sunscreens, particular brands of supplements, and I just wanted to say that I have no financial interest in any of those companies. At its most basic, the role of the immune system is to distinguish between self and non-self. Infectious organisms have different components on their surface that allow our immune system to recognize them as foreign and hopefully fight them off before they cause infection. Cancer cells also start to express different components on their surfaces that allow the immune system to recognize them as abnormal and hopefully eliminate them before there is chance for a tumor to form. Cancer is the leading cause of death after infections in patients with primary immune deficiencies. Lymphomas are the most common cancer of death due to cancer in immune deficiency. Skin cancers are a much smaller fraction, but they're more easy to detect and they're more easily treated, so I think it's important to know about. This diagram highlights several factors involved in cancer development. So the central ones being immune system insufficiency and infectious agents. So if your immune system can't recognize a cell that's become a cancer cell, it could escape detection and become more serious. Infectious agents can trigger cancers on their own. And then there's an interplay where if your immune system can't fight off those infections effectively, you're at even higher risk. These are some infectious agents implicated in specific cancers. So Epstein-Barr virus is associated with a number of different types of lymphoma. The human papillomavirus is related to squamous cell carcinoma, and that's in the skin, mouth, anogenital region, and in the cervix. Human herpes virus 8 is linked with the tumor of blood vessels called Kaposi sarcoma, and the polyomavirus is linked with a more rare but serious skin cancer called Merkel cell carcinoma. So now just some data showing that people with primary immune deficiency disorders are at higher risk of some cancers. This data comes from the USID-NET, a research program of the Immune Deficiency Foundation, where they compared the cancer incidence in over 3,500 patients with primary immunodeficiency diseases to patients in the surveillance, epidemiology, and results, or SEER data of the National Cancer Institute. That group is a much larger group, as you can imagine, compared to the 3,500 patients that are in the USID-NET. The key points from that study were that of all the cancers that were reported, only lymphoma and skin cancer had a statistically significant increased incidence compared with SEER data. Lymphoma was diagnosed 10 times more frequently than in matched controls from the SEER data, and skin cancer diagnosis was 4.5 times more frequent. But is the SEER group a fair comparison when it comes to skin cancer? I really don't think so. So it's not apples to apples here. The USID net includes all newly diagnosed skin cancers, whereas the SEER only included newly diagnosed melanoma cases. For that reason, this series likely overestimates the increased incidence of skin cancer in primary immune deficiency disorders. Well, what about secondary immune deficiency? There are a wide range of conditions that can lead to secondary immune deficiency, but the top one I encounter in my practice is patients who have had organ transplants. The immune suppressing medications used to prevent rejection of transplanted organs causes a large portion of secondary immune deficiency. And transplant patients on immunosuppressants are more likely to develop cancer than the general population. And this is especially true for cancers linked to viral causes. Skin cancers account for 40 to 50% of the cancers diagnosed in transplant patients. So this study compared skin cancer incidence in transplant patients compared with the general population. And the range of increased incidence is pretty broad, but I think there's still some important things we can learn from this. So Kaposi sarcoma was 84 to 500 times more common, squamous cell carcinoma 65 to 250 times more common, Merkel cell carcinoma 24 times more common, basal cell carcinoma 10 to 16 times more common, and melanoma 0 to 8 times more common. One thing that I think is important about this information to point out is that it is the cancers that have associated viral infections that have the largest amount of increased incidence. So again, that's Kaposi sarcoma, squamous cell, and Merkel cell. So UV radiation and skin cancer. UV radiation can directly cause mutations in skin cells to initiate skin cancer, but also UV radiation can cause local immune suppression in the skin, and that can further contribute to the development of skin cancer. Patients with the highest risk of skin cancer before their transplants are the ones who have the highest UV exposure prior to their transplant. So it's definitely a combination of sun exposure, sun damage, along with the immune suppression and viral infections that lead to the overall increase. The three most common skin cancers are basal cell, squamous cell, and melanoma, and that's also in the order of seriousness. Basal cells are virtually always confined to the skin and are easily treated. Squamous cell carcinoma has a bit more potential for spread to lymph nodes and beyond the skin with some risk of mortality. And then melanoma of these three has the highest chance of spread to lymph nodes and other organs, which can then become fatal. In the setting of immunosuppression, the order in terms of how frequent they are is different. So squamous cell and basal cell are flip-flopped, melanoma is still number 3. And the reason for that change is that squamous cell is the one associated with viral infections, so that plus the immune suppression makes it number 1. All of the images that I'm going to use from here on out, the clinical photos, are from a website called DermNet NZ, and it is a great place to find reliable information on all sorts of skin disorders. And they have a very large catalog of images that they make available for educational use. We'll talk about basal cell first. So these are all basal cells. They are typically pink and shiny, or you'll hear dermatologists use the word pearly. They tend to be a raised bump with dilated vessels. And I believe in the left and middle photos, you can see some very tiny vessels there. They can also have an indented or crusted center like the photo on the right. They tend to bleed easily and to slowly enlarge over time. There are some harmless growths that can look very similar, so especially to the picture on the left with the one by the lip, that looks very similar to a pink mole. So I'll often ask folks, how long have you had this? If they say, oh, it's been there for years, that's typically reassuring. On the other hand, I'll also ask about bleeding, like has it bled when you wash your face or towel off? And if they say yes, that raises a bit of a red flag. These are also basal cell carcinomas, but ones that are a little bit less common, but good to know about. So on the left is one type called a superficial basal cell, and it can resemble a rash that won't heal. It typically isn't itchy like a rash might be. It won't respond to treatments like over-the-counter or prescription cortisones, and it lingers for months. The middle photo is a pigmented basal cell, and in addition to pink areas, those can have grayish or brownish areas within them. The image on your right is of a type called morpheaform or infiltrative basal cell, and those tend to resemble a scar. When I see someone with a scar on the face that looks at all unusual, I like to confirm, do you know how you got the scar? When did it happen? If they're unsure, I ask, has it been growing? Has it bled? And I would, pay more attention or recommend a biopsy if there weren't a good explanation for it being there. Now I'm going to move to squamous cell carcinoma. This one tends to be more scaly or crusted instead of smooth or shiny, like this one on the left. There are forms that can grow more rapidly and resemble a boil, and the one on the middle is typical of that presentation. And just like for a superficial basal cell, there's a superficial or in situ form of squamous cell that grows more slowly and can look like a rash that doesn't heal. So there's some special locations for squamous cell that are important. When it occurs on the ear or on the lip, these are locations that are more likely to spread beyond the skin to lymph nodes. So, we'd love to pick those up early. May need to work with radiation doctors in addition to surgery to treat some of these more serious ones. And then I included the photo of the one on the finger because, I guess sometimes something like this might be confused with a wart or a skin infection, but it's a squamous cell. This type that occurs on the finger does seem to be more strongly linked with the HPV infection. For melanoma, we often talk about the ABCDEs as signs to look for. The E is a newer addition. The ABCDs have been around for a long time. They were developed by dermatologists at NYU to try to promote early recognition of melanoma. So the A is asymmetry, B, border irregularity, C for color variation, D for diameter over 6 millimeters or very dark. The diameter was the initial D. There's kind of a movement to change it to dark because something very dark or black may be more predictive of a melanoma than just something based on the 6 millimeter size. And there are frequently melanomas that start at a size below 6 millimeters that we don't want people to ignore. The E that's been added is for evolving or enlarging. These pictures of melanoma all show the ABCD criteria. If we were to draw a line, halfway through each of them, the halves wouldn't match up. The borders are irregular. we're seeing multiple shades of brown, tan, black, and also some pink and whitish areas. In terms of the D, some of them have very dark areas, and the ones with rulers you can see are larger than 6 millimeters. So there are, I think, some other important strategies to use, but first let's talk about the E for evolving, the importance of change over time. So this series of images shows the same mole and how it changed to the point where it was biopsied and proven to be melanoma. Fairly innocent looking in that first picture, but kind of becomes more irregular, multicolored over time. Okay. I like this one, the ugly duckling sign, especially for people who have a lot of moles and feel overwhelmed that they would have to look at each one for the ABCD features. So the idea is just that a mole that stands out or looks different than surrounding moles is the ugly duckling. And depending on how different it stands out and whether it's changing, it could either be something to just follow more closely or to biopsy. I'm going to try to use the pointer here. So I think if we look at this photo, we can easily say that that's the one that stands out. And in this image, this one. And this one I think is a little bit trickier, but this one is a little bit larger and has more color variation than this one or the freckles in the background. So let me go back for a second. So all of these pictures, and particularly these that have the ABCD criteria very prominently, these are all examples of a type of melanoma called superficial spreading, and that's the most common form. A good thing about that form is that it tends to spread outward on the skin, giving us time to recognize the abnormal appearance before it spreads very deeply. But there are other forms of melanoma where that's not true. And so I'll go back to my slide about nodular melanoma. So it's one that springs up pretty quickly as a lump. It's more likely to metastasize and result in death than a flat melanoma. I found this EFG idea on the DermNet NC website. I hadn't heard of it before, but I think it could be a really helpful tool. So we're looking for things that are elevated, firm, and growing. And these are examples. So you can see that, they're all raised above the skin. They can be very dark or multicolored, but sometimes they're pink. For example, the one on the ear, I think, could easily be diagnosed as a basal cell just by looking. I think if you're looking at your skin periodically, this one should be pretty easy to pick up because of how rapidly it changes. I wanted to include a few pictures of Kaposi sarcoma just because we mentioned it along with the slides about viral infection and skin cancer. So it is a cancer of vessels, tends to make red or purple patches, bumps, or nodules on the skin or in the mouth. The human herpes virus 8 is the virus that's associated. And this was a lot more common during the AIDS epidemic before we had effective antiretrovirals. There are other groups of patients that seem to be at slightly higher risk, and elderly Mediterranean males is the other group that's commonly talked about. These are pictures of Merkel cell carcinomas, sometimes described as a neuroendocrine cancer, and it tends to be a pretty nonspecific bump or nodule, but it does tend to favor sun-exposed areas, most commonly the head and neck. It's more common in the elderly, thought to be from waning immunity as we get older, and it's linked with this polyoma virus. So now I'll move on to sun protection. I talk a lot in the office about sunscreens, but I think as much or even more important would be the things up top here, like limiting your overall exposure, limiting your exposure during peak hours. The peak hours of 10 to 2 are most often quoted, but I would recommend that if you're out for more than a half hour between the hours of 9 to 5, that you would wear sunscreen. Seeking shade where possible is also helpful. Wearing sun protective clothing, a hat and sunglasses is a great idea, along with sunscreen and possibly supplements. So this is how dermatologists enjoy the pool. This is my brother and I at the pool, but we don't usually wear these face masks. I did ask him for one for a birthday present because I was intrigued after seeing an article in the New York Times about how it was a craze in some Asian populations and people wearing these on the beaches. But I do a lot of the things here. I do wear the rash guards. So sun protective clothing is defined with the UPF or ultraviolet protection factor, which is the clothing equivalent of SPF. And ideally, you'll look for a number of 50. Coolabar and Solumbra are companies that have specialized in sun protective clothing for many years. But in recent years, many outdoor stores, athletic stores, other mainstream stores have started carrying UPF rated clothing. So I think it's great. Things have come a long way in terms of the types of items that are available, the fabrics, colors and patterns, and hopefully that'll make people want to wear them. So it doesn't have to have a UPF rating in order to protect you from the sun, but for regular clothing, tightly woven, thicker material and darker colors are likely best. And the white undershirt was a common thing to see on the beach when I was growing up, but a wet white undershirt only has a UPF of 3, so not very protective. For sunscreens, the AAD advises use of a sunscreen that's broad spectrum, which means it protects against UVA and UVB, is water resistant, and now the labels are required to say whether that's for 40 or 80 minutes, and an SPF of 30 or more. One of the most common questions I'm asked, especially in spring and summer, is which sunscreen is best? And it's complicated now more so than ever. So we'll talk about some of the reasons why next. So I put SPF 30 versus 1000. Well, that's probably going overboard, but SPF 30 versus 100 might be something more reasonable to think about. So does the higher SPF make a difference? It depends. If you apply your sunscreen very liberally and you reapply according to package directions, it probably doesn't matter very much. But most, if not the majority of us, apply too thin of a layer and don't reapply as often as needed. And now there are real-world use studies of sunscreens showing that most people get half of the number on the bottle or less due to inadequate application of sunscreen. And then this more recent study showed that even when you compare a high SPF sunscreen like 50 to a 100, it still seems to make a difference. So, that was a well-conducted study. There were fewer burns with SPF 100 than with SPF 50. Are chemical sunscreens bad for you? There are studies showing hormonal changes in lab animals exposed to the sunscreen ingredient oxybenzone. It's not really clear what significance that has in humans, but last year, a study was done looking at 4 sunscreen ingredients under maximal use conditions, and that meant that sunscreens were applied to 75% of the body every 2 hours for 8 hours. And under those conditions, all of the sunscreen ingredients they studied were detectable in the blood. So that really got my attention, but I thought, well, that sure is a lot of sunscreen. Are people really applying it that much? And I didn't feel too worried about it. But now if you look below this study just in January, of chemical sunscreens showed that even after a single application, you can find these in the blood. As of yet, there are no proven health problems that causes, but it's certainly going to be under investigation. Are chemical sunscreens bad for the environment? There's evidence that some of them may cause harm to coral and have other negative effects. Hawaii and Key West have banned the sunscreens containing oxybenzone and octinoxate, and many sunscreens now are marketed as reef safe. But there's no set definition of reef safe, and it's not something that the FDA regulates. Right now, I feel like it's almost a marketing tool similar to how foods might be marketed as all natural without being regulated or having a set definition. So this picture just goes over how the sunscreen you apply may end up in the water and harm animal life. I like that it has everything on the bottom row that you can do to protect yourself that could result in needing less sunscreen in the first place. Well, what about physical sunscreens? Those are zinc oxide and titanium dioxide. They tend to leave a white residue. I think maybe some of us, depending how old you are, can think back to people having just the purely white zinc oxide on their noses when they're outdoors in the summer. The white residues now are not nearly that thick, but they're still there a bit and make it a little bit harder to use. It's partially overcome by micronized formulations of the ingredients, but there are theoretical concerns, both health concerns and environmental concerns related to nanoparticles. And that's, again, another area of study. The physical blockers aren't as good at protecting against UVA as chemical sunscreens. What about vitamin D? So low vitamin D contributes to the disease of bone called rickets. It may have a role in cancer prevention and immune function, but there have been some large trials that have yet to prove this. Vitamin D can be obtained through diet, supplements, and exposure to sunlight. But the skin can only manufacture a limited amount in a single exposure. So it's not as if you stay out, for 2 hours, you're going to get your vitamin D up more than if you stay out for 10 or 15 minutes. Lotions or sprays? The lotions provide better coverage, but sprays sure can be more convenient. The safety of sprays are being evaluated by the FDA, with the main concern being inhalation. So it's best to use these outside in a well-ventilated area and avoid spraying it on your face. You should spray until the sunscreen's visible on your skin and then rub it in. With all these issues, what's a person to do? And I think reasonable people will make different decisions, and that's okay. One of the main things is don't forget the basics. You can limit your overall exposure or your peak exposure, seek shade, and wear some protective clothing. You won't need as much sunscreen. But I would recommend that you consider a high SPF chemical sunscreen for prolonged or intense exposures. Consider a high SPF physical sunscreen if you have concern about the chemicals. And consider a high SPF physical sunscreen if you'll be swimming in the ocean. It would be reasonable to spend 10 or 15 minutes a day in the sun without protection if recommended by your doctor based on low vitamin D levels, particularly if your doctor thinks you're at low risk of skin cancer. I would recommend that people use lotion or cream for the first application before going out and reserve sprays for reapplication. One of the main resources that I use to help evaluate sunscreens is Consumer Reports. And that's because for years now, they've been doing independent testing of UV protection for a large number of sunscreens. And each year they put out a big list of these. The information I'm showing you here is from the online portion of Consumer Reports, but I expect that probably in July, the paper issue will be on newsstands. So in their testing, these are the top performers just in terms of how effective they are. So Coppertone Ultra Guard Lotion SPF 70 was the top lotion sunscreen. Trader Joe's SPF Spray 50 is the top spray. And then for lip products, Aquaphor Lip Protectant with SPF 30. And thinking about the lip product just makes me think back to the slide I showed about the squamous cell on the lip. So, don't forget to protect your lips. We don't want to have that happen if we can avoid it. No mineral sunscreens make the recommended list based on UV protection, predominantly because they don't do as well at UVA. But these are the two that scored higher than others. So California Kids Super Sensitive 30 and Badger Active Unscented 30. These next two could be a compromise for people who want the more effective chemical sunscreens but would like to avoid oxybenzone, which is the one that has the most concerns at this point. So Walgreens Lotion SPF 50 was their top lotion, and Hawaiian Tropic Sport Ultralight Spray with 30 was the top spray without oxybenzone. Unfortunately, we're going to have to keep reading the labels. Most brands make multiple formulations with different physical and chemical sunscreen ingredients, and formulations may change from year to year. So the potential role of supplements. The product called HelioCare contains a botanical extract from a fern native to Central and South America. It has photoprotective, antioxidant, and chemopreventative properties. And for a long time, it was only available as a single ingredient product. In 2015, the New England Journal of Medicine published a trial showing that taking the B vitamin niacinamide twice daily for a year resulted in 20% decrease in new basal cells and a 30% decrease in new squamous cells compared to placebo. The study patients in this trial were people who were already at high risk of sunscreen and who had already been diagnosed with previous skin cancers. So they'd already had skin cancers before entering this trial. And I bring that up just to let you know that the benefit for someone at lower risk may not be as high as what they demonstrated in their study. Now there is a product made by HelioCare called HelioCare Advance that combines both ingredients in a single product. So I think that's definitely something to consider if you have already had skin cancer, and maybe something to think about as a preventative agent depending on your risk level. So this is my intro slide again, and I hope that I've discussed some basics about the immune system and the prevention or formation of cancer, presented some information on increased risk of skin cancer, particularly skin cancer in patients that have immune deficiency. We've talked about how the immune system, viral infections can work together to trigger skin cancers. I hope you feel that you're better able to recognize the 3 most common skin cancers and that you can make more informed decisions about sun protection. Thank you again for having me and for your attention. Just showing that our family, we do try to practice what I preach. My husband and I are hiking in that picture on the left, and my kids wearing their rash guards on the right. I'd now be happy to take any questions.
Thank you, Dr. Dasher. We're going to open it up to questions now. You can also ask your questions on the right in the little toolbar. I do have a couple of questions already, and you can type those in at any time. So one question is, where do you find UPF clothing? Is there a specific stores that carry that, Dr. Dasher?
Yes. So, I mean, you can find it really, I feel like almost anywhere at this point. So they have that kind of clothing available at places like Target and Walmart, department stores, athletic stores, outdoor stores, like clothing marketed to fishermen often is UPF rated. But those two companies I mentioned, Coolabar and Solumbra, are ones that are particularly focused on UPF clothing. And they have paper catalogs, but they have good online sites where you can shop for those things if you're interested.
Great, thank you. How long does it take to develop Kaposi carcinoma or squamous cell carcinoma on the mouth, and what should an individual look for in their mouth? This is not usually a place people think of when thinking about skin cancer.
Mm-hmm. That's a good point, because there's certainly a lot of more common things that can show up in those areas, like in terms of the lip, you know, many people get cold sores on the lip, which could look somewhat similar to that picture of squamous cell that I showed. And, you know, but that has a much shorter length of time, so we would expect it to heal over a couple weeks. Whereas with a squamous cell on the lip, I would expect that to be something that starts a good bit smaller, becomes larger and more crusted over a period of several months. So I tend not to feel so worried if we're not sure whether something's an infection or a pimple or a scratch until it's been around for 2 or 3 months. We feel like sure it's not something that's going to go away on its own. The caveat would be that if you've got one of those rapidly growing types of skin cancers, you know, we're going to become more concerned much more quickly. In terms of the mouth, you know, I would expect that to take months to develop as well. And I think probably the most common thing I see in the mouth would be blood blisters. Maybe you don't realize you've bitten the inside of your cheek and you've got a dark black or purple spot. And there are also harmless blood vessel growth that can come in the mouth or on the tongue.
Thank you. What's the first thing a person should do if they suspect they may have a cancerous lesion?
I would like to say the first step is to make an appointment with a dermatologist, and I think that would be great. But depending on where you live, access to dermatology can be pretty difficult. So in the event that you can't get directly into a dermatologist, I would talk to your primary care doctor, let them evaluate the spot, and they can then facilitate getting you in with a dermatologist depending on how concerning it looks.
I'm concerned about a spot on my face, but with the COVID, I haven't been in and wonder if I will even be able to get it checked out. Any thoughts?
Sure. So a lot of practices, including Tryon Medical Partners, are offering virtual visits. So that's something that could be scheduled. I think it doesn't take the place of getting to see someone in the office and use sort of a lighted magnifier that we use to help see more details. But if you have, if you can take a good quality cell phone picture, we can upload it into the virtual visit platform that we use, and we can often have a sense of how urgent it is and whether it's really important to come in now or whether it's okay to wait a couple months.
Thank you. I am primarily 90% covered by clothing when outdoors and use Elta MD SPF 46 on my face when outdoors. Is that a good sunscreen?
I really like those products, the Ulta MD, and I've used them myself. They're really nice, kind of rub in well, and they have nice high numbers. So I think that's great. I wish that Consumer Reports would be able to evaluate even more brands, but that's not one of the brands they test. But I do think it's a high quality product line.
How should we balance sun protection clothing and our need for vitamin D? If wearing protective clothing, can we receive any vitamin benefit from the sun?
I think it would pretty much only be on what's exposed and what small amounts could penetrate your clothing. So if you have concerns about your vitamin D level, you're practicing sun protection so well that you think you might be deficient, that's definitely something a primary care doctor can check and then guide you on whether they think it's better to get some natural sunlight without protection on a regular basis, or to take supplements or increase dietary intake of vitamin D.
My daughter, who has primary immune deficiency, has a couple of large raised moles on her scalp. We did have one removed by a plastic surgeon when she was younger, and there were no issues with it. Should we have the others looked at?
I think that pediatricians are great at evaluating moles in kids. They see them all the time. And also at the same time, I think they have a low threshold to send a child to a dermatologist if they have any doubt about whether it's harmless or not. So if I will often tell parents, if you're not sure whether your pediatrician took a good look at the mole or not, just ask, say, I've noticed this mole, what do you think? That'll make them pause, take a closer look, and maybe kind of assess with you, is it something that you can monitor on your own, or whether you need another opinion.
Well, she just also added to that question that she's an adult now.
Ah, okay. Well, I guess I would say it's hard to know, I think, with these less, the conditions that you all are so familiar with are quite rare, and often so much that I can't tell you the exact risk that you're under. So I would think about your other risk factors, like, do you have a family member with melanoma? Have you had severe sunburns over your lifetime? Do you have family members who have a lot of atypical moles? But I think it can never hurt to get a baseline check. And just like a pediatrician will look at moles in kids, an internist or family doctor is familiar with looking at moles in adults. And if you're concerned and let them know, I think they would have a low threshold to get another opinion.
What is the prevalence of COVID toe? Do we know this statistic yet?
I don't think we do, because so if the registry caught the total number of people with COVID toe, then we'd have to know the total number of people that are diagnosed. So I think it's really hard to say at this point, but it does seem to stand out that there have been a lot more cases of that shown than of any other type of rash. And, maybe with more time, the registry that the AAD is doing will allow us to have a better idea.
Besides Epstein-Barr virus and a couple of others that you mentioned, are there any other specific viruses that put a person at risk to develop skin cancer? And is there anything that can be done to prevent that from occurring?
So it's hard for me to think of another viral infection linked with specific cancers. I mean, in a way, you could say any viral infection that suppresses your overall immune system could make you more susceptible. And like the HIV virus, it doesn't actually cause Kaposi sarcoma, but it lowers your immunity enough to where the human herpes virus can cause it. But, I think that there's not a lot active than you can do. In terms of a lot of these viruses, they're very common in our environment. Some of them, like HPV, are even found present on normal skin. I guess in terms of HPV, it would be good to make sure that women have pap smears as recommended by their doctor. That could, detect or prevent cervical cancer. But it's hard for me to think of another example or other measures to take.
Okay, thank you, Dr. Dasher. Are there any other questions for Dr. Dasher right now? Feel free to type them in. I did want to mention right after we conclude today's webinar, if you'll just take a few moments to answer a 5-question survey after the webinar, that would help tremendously. Like I said, super quick, 5 questions. We really appreciate it. And we really appreciate you listening this afternoon, and also hope that you'll save the date and join us for our next educational webinar, which is going to be on May 28th from 6 o'clock to 7 o'clock Eastern Time with Dr. Del Santos, who is a practicing rheumatologist in Rochester Hills, Michigan. And it is Behçet's Awareness Month, and he will be speaking on Behçet's disease, which is a rare autoimmune condition. Thank you, Dr. Dasher, for sharing your time with us today. And today's webinar, thank you. Today's webinar is going to support the purpose of AAIDA, which is to educate patients, providers alike, to advocate for patients living with immune disorders, create awareness about immune disorders, and to make strides in research to find cures and novel treatment options for these diseases. Please visit our website at www.godoaida, that's with 2 ways, .org for more information and resources. This is Lauren Dunlap for Advocacy and Awareness for Immune Disorders Association, and we hope you have a great and healthy day. Thank you so much for your time.